enhanced BH email address and enhancedbh@dmas.virginia.gov, and we will answer those in a timely manner. I also want to note that Director Karen Kimsey of the Department of Medical Assistant Services is here with us this morning, and this afternoon, she'd like to give a welcome statement.
Hi there. Thank you, Dr. Ward. Good afternoon, everyone. I hope everyone's doing well today. I'm so excited to see virtually see so many people on the line today to hang out with us today as we talk about our proposed enhancements for Medicaid behavioral health services. So important. And we, as Dr. Ward mentioned, we were very pleased about where we're heading with these critical changes, but because of COVID, we've unfortunately had to place them, I would affectionately say, on hold for just a little bit per the legislature and our administration while we deal with COVID. And we know you all are also experiencing these issues at the same time with us in dealing with supporting our members and also with managing your businesses. And so we appreciate that time, and you have our full assurances that as soon as that we address COVID and we're able to get the green light, that's what's so important for these conversations to have right now, because this is one of our agency's top priorities to make really positive advanced changes for evidence-based solutions to best support our members and support you as our providers. And so very excited to still continue talking about this, and our teams here at DMAS, as well as the very talented teams here, live at Dr. Ward and also with her team and Tammy, and also all the talent with Dr. Oplaska and all over at the Department of Behavioral Health and Developmental Services are working very closely in tandem to work on this and to plan. So when we do get that green light, we will be working very closely with you to implement these changes as soon as possible. So thank you again for your time and attention. We look forward to addressing any questions that you have with us at the end of the presentation. And I'll turn it back over to Dr. Ward.
Thank you so much, Director Kimsey. And my team would just really like to thank Director Kimsey and my deputy, Tammy Whitlock, for their incredible support throughout this process and in staying committed to this project, even through COVID. So thank you so much. We are going to move to the next slide, where you all will see the smiling faces of myself and Dr. Oplaska, who is my partner in this process. She is the Chief Clinical Officer at DBHDS, and we will be handing the mic back and forth today fluidly as we provide you with these updates. Slide. For those of you who have been with us since the beginning, this is hopefully a very familiar slide to you, but we know that we may have new folks who are joining on the call, and we wanted to just reiterate this vision, which has not changed. If anything, this vision has been strengthened through the COVID-19 state of emergency as we continue to see that there are enhancements needed for our system, and they follow the values that you see on this slide. So the goal here has really always been to build out a full continuum of behavioral health care for our Medicaid members, and to really assure that across every level of care, there are comprehensive services that are high quality, that are based on the evidence, on what we know from science to work, because we do have a large body of that evidence gathered. And so we really want to put it to work here in Virginia. We want to focus on the prevention and early intervention ends of that evidence and really move our members towards least restrictive environments and focusing on their natural supports and keeping them in their communities and homes. Likewise, we really want to come at this enhancement with a trauma-informed lens, and keeping in mind that that lens is deeply affected by historical trauma, by race-based trauma, and acknowledging those and keeping those in our mind in terms of how we can address trauma and health disparities through improvement of the services that we offer and the workforce that we support in that work. Also, we're always aware we're working with public funds, and those are always, they are not limitless. And thus part of our duty in these roles as public servants is to assure that we are cost effective and that we make the best investments possible with the money that we have to make the most change and the most supportive enhancement for the members that we serve in the work that we do. And so that is, of course, an obvious driver that goes on in terms of how we think about bringing change to the system. Next slide, please. We have also from the beginning always talked about enhancement as the big hug that goes around all of the amazing work that came before it in the system and the work of all of our fantastic colleagues across agencies that have been walking together through this process in an unprecedented level of coordination and collaboration. We have continued to work closely with the Department of Social Services and Office of Children's Services around the implementation of the Family First Prevention Services Act, which is likewise on hold right now. We have acknowledged from the beginning that these two implementations have overlapping membership in terms of who is participating in the service. They have an overlapping workforce, and that it was critical in terms of cost effectiveness and also just alignment and making sure what is offered mental health and behavioral health wise across the system makes sense and works together, that we be on the same page as them and that we be seeking to, for example, establish rates in the Medicaid system for services that would be offered through that implementation of that act. Likewise, assuring that there's alignment across outcomes and operationalizing the services so that providers like many of you who are on this call today are not having multiple expectations from multiple systems. So that is an example we've also learned very much from the incredible work done by our partners at the Department of Juvenile Justice and the transformation of their system and the movement to prevention-focused, evidence-based, community-based services. And we've learned a lot from their admirable implementation of multisystemic therapy and functional family therapy across Virginia, more recently expanding into even more rural communities and really seeing the power that those interventions can have for those communities and those kids at risk for juvenile detention. And so we know that those have also been of great value to children receiving funding through the Children's Services Act, and we're hoping to expand upon that through Medicaid. We also participate in the Governor's Children's Cabinet and their focus on trauma-informed care. And so, as I mentioned before, those values and that vision has been infused throughout this proposal. And we continue to participate in those conversations and assure that the goals of this project remain aligned with the idea of addressing adverse childhood experiences and their impact across the lifespan. As you can see on our alignment wheel, as we call it, there are a number of other projects across the state that have come before us and are walking along beside us that we don't have time to get into today. But in the next slide, Dr. Aplaska is going to speak in more detail about the STEP Virginia process and how that really has been built to go hand in hand with enhancement.
Right, so this next slide is something that most people have seen before who have been involved in the stakeholder work groups, and I understand these meetings are a little bit broader reach, but this really speaks to the intersection of our agency's major behavioral health initiatives, which is STEP Virginia, led primarily by DBHCS, which are services that improve access, increase quality, build consistency, and strengthen accountability across Virginia's public behavioral health system, which right now is provided by the CSBs as the safety net providers in the communities. This has been underway for several years now, as it went into code in 2017, I believe. And so behavioral health enhancement is really intended to build off that foundational structure. So overall, transition the funding to outpatient services and integrated services in primary care and schools, as well as intensive community-based and clinic support, invest in workforce development, including the provision of adequate reimbursement to recruit and incentivize providers to serve where they're most needed, also reduce the regulatory burdens and licensure that impede workforce development. And then part of that, what we proposed this General Assembly and went through was the implementation of 6 high-quality, high-intensity services that have demonstrated impact and value to patients. And so these are services also that were chosen because they currently exist and are licensed in Virginia, but they're not covered by Medicaid, or the service is not adequately funded through Medicaid. So some examples, so these are the 6 services that were proposed as part of this phase of implementation: partial hospitalization and intensive outpatient programs, which are funded through Medicaid through the ARTS program, but really not very well funded or not at all funded through their mental health benefit. And we know that that is critical as a step down or diversion from inpatient hospitalization. And then Program of Assertive Community Treatment, or PACT, which is available again in Virginia through the CSBs, but not every CSB, and it is primarily through general fund dollars. And so by integrating and utilizing Medicaid dollars, that creates a huge opportunity to expand the breadth of and scope of PACT to reach more communities and establish more teams, as well as continue to build upon the evidence-based and high-quality service that it is as a critical need. Multisystemic therapy and functional therapy is one that we've talked about also in our stakeholder groups as services that exist, but the nature of those services are highly intensive. The providers are available, particularly for MST, available 24/7, and right now really have limited access, primarily through DJJ and a very small scope outside of that. So they're not funded through the current Medicaid rates, and so the intent there was to be able to make those accessible by developing a Medicaid rate for those services. Comprehensive crisis services is critical to any well-functioning behavioral health system. Medicaid currently reimburses for different types of crisis services, but by no means is this sort of kind of envisioned as a comprehensive continuum of care at that level. And those are really critical because we are still facing a significant census pressures at our state hospitals. And so we do have to meet people where they are, and right now they're in the highest levels of care. So we do need less restrictive, step-down alternatives to help with that psychiatric bed crisis and continue to build out the system. They've also demonstrated cost efficiency and value in other states. So we looked at what we need here in Virginia, and then also looked at what other states have done to be able to meet those significant challenges and the return on investment that's had on their community and their mental health system. And so these are some examples of that, which we have proposed. Next slide.
So the good news that we have to share today is that we have spoken with both boots on the ground, folks who've been providing these services here in Virginia, as well as the developers of these services who've been able to provide us with data about how the services have been resilient during the COVID crisis. And, this is an important question as we think about timing, timeline, what is really feasible to do for the short and long term if we are managing an implementation during social distance. These are really, to use an overused word right now, unprecedented circumstances to plan an implementation around. But the good news here is that we have learned that multisystemic therapy and functional family therapy have been able to shift to a combination of telehealth and some limited face-to-face interventions. They've continued to have positive outcomes. This has, really come to the pleasant surprise of even the developers of these treatments, who traditionally had some pretty strict limitations around the amount of telehealth versus face-to-face delivered proportions of the service. but they have seen that they have done really well, and that we've really had live data to demonstrate that not only has the utilization not really decreased, but families are remaining engaged, and the outcomes that they measure through their regular fidelity measurements have not been affected very much. So they've really seen that they've continued to be strong deliveries even during the state of emergency and under kind of a flexible adaptation of the delivery. We've seen the number of teams continue to grow in Virginia during COVID. They've continued to train during this period, and that is really hopeful as we think about training additional work groups, workforces through social distance potentially, as we don't know when the end of this period may be. So all good news there. And then just want to give a big shout out. If you could see me, I almost want to go on the screen. I said this in the last call as well, and give jazz hands to the PAC teams, but I am giving them jazz hands right now. Virginia's PAC teams across mostly our CSBs have continued to deliver services throughout COVID. They've been incredibly committed, and they have not seen lower members in attendance. Some have even experienced growth. We've even added an additional PAC program in Virginia. They have really been out there and been doing the work and have done it very well, considering this time of crisis. And so we do know that there are paths forward here, that COVID can't keep us down, that the workforce is committed to finding creative ways to maintain contact and continue delivery of these services. Next slide.
So this slide also speaks to the practices that we have seen and are being reported to us in terms of how they are able to manage sustainability during the times of COVID. So the partial hospitalization programs and intensive outbreak programs, which are staffed with licensed professionals, are still able to deliver those professional services. Many of them have been able to provide a combination of telehealth and face-to-face treatments. We're seeing a lot of really innovative work and strategies and ideas that have come out of COVID, of course, out of necessity and keeping people safe and adhering to the public health guidelines, but also being able to meet needs of people who are receiving mental health services. There's also been a large shift, an increase to outpatient mental health providers due to individuals choosing the least restrictive care. So as you can imagine, because of COVID, a lot of the in-person, in-group setting services have been really limited, and not to say that they're not still needed, but the providers have found alternative ways to still provide support to people and meet their needs. And then the comprehensive crisis services continue to be necessary to reduce hospitalization, some of which have been performed through telehealth when clinically appropriate, including some of our creative partners at the CSBs who have done TDO evaluations via telehealth for multiple reasons, to limit the number of face-to-face visits because of COVID due to the limited supply and significant shortage of PPE. And so, helping our kind of medical colleagues on the front lines to make sure that they have available PPE, and also, providing services and TDO evaluations to emergency rooms and avoiding the emergency room altogether so that they are not unnecessarily exposed to certain risks in the communities where they provide care. We did experience at the state hospital system a little pause when we had our very strict shelter-in-place mandates from the governor. And now, as we have entered phase 3, we are now moving into a phase where our state hospital system is again at census or above, still while COVID in the background. And so comprehensive crisis services are needed now as much as ever.
On this next slide, this is really just a reminder of the original governor's budget allotment prior to COVID. for on the Medicaid side for behavioral health enhancement. So what you can see here is that the cost of this implementation was split out across the biennium with kind of a staggered implementation with multisystemic therapy, functional family therapy, and PACT, which were already really had their seeds planted in Virginia and would just be expanded with a new rate and hopefully additional workforce starting in January 2021, followed by implementation in July 2021 of a comprehensive crisis service system aligned with STEP Virginia, and then the partial hospitalization and intensive outpatient programs. So you can see how that was laid out. And then for the next slide, the grumpy coronavirus face will come in to just note that these funds were unallotted, which really effectively means they were frozen when COVID hit. And so this does not mean that they are gone altogether. It means that they're frozen until the General Assembly can make its best judgment about prioritization of resource and determine, when these may become available again. So they're on hold, as Director Kimsey said, they are frozen. And so next slide, Dr. Plaska can speak to the workforce funds on the DBHDS side of the budget.
So also as part of the budget, we was $1 million in FY 2021 and $1.2 million in FY 22 for workforce preparation and development and preparation for behavioral health enhancement. Those have also both become unallotted. And so I don't have the grumpy coronavirus face on here, but my personal face is grumpy about that. So you can imagine that. We also still have the language to align DBHDS licensing with the Medicaid behavioral health services. And this was a language only and allows us to promulgate emergency regulations. There was no dollar amount associated with that. And we have moved forward with putting those regulations forward. So we don't know when those funds would become unallotted, but we certainly don't want licensing to be the barrier once to implementation. And so that is still a critical component in our licensing team. Work very hard to make that, put that forward. So I just want to recognize them there.
So the next slide, again, a review to provide kind of reflection on what our initial implementation steps had been planned to be, which was, once we anticipated authority being granted to proceed from the General Assembly, that we would reconvene all the stakeholder work groups that many people on this call participated in to engage in the next step of implementation planning, which is installation. So figuring out all of the operational details of how to bring these services to bear. And so that would involve systems changes on the MCO side for our BHSA, for all of the providers. It would be making the changes to our state plan amendment and submitting that, regulation and manual changes and updates, and then launching statewide workforce training. That would be paired with the development of metrics and public-facing dashboards with stakeholder input so we could report out on implementation progress and outcomes from these services. And this would all be aligned with preparation for a potential 1115 serious mental illness waiver, which would allow us to pull down a federal match and open up additional services, residential services, higher level of care for those with serious mental illness that we serve. Again, as a reminder, our current service system does not really allow us eligibility for the application for that waiver because we have to demonstrate that we already have a comprehensive evidence-based system in place in our community-based services. So we really aren't even eligible to begin that process, but we anticipated that once we kind of had enhancement planned, approved, and in the installation phase that we would be able to begin to engage in that conversation with CMS. So that had been the plan to this point. Then Grumpy Corona came in the way. And so we have adapted and thought about a new plan, which would be once funding, we hope, fingers crossed, would be reallotted through the special session. Then we would reconvene the stakeholder work groups and start this process again. We also want to emphasize that we have been, very in touch with the pulse of what is happening in the community, that we are want to be responsive to that and to think about how we can continue to evolve our thinking and grow and kind of widen our thinking around the need for improvement. And, we all on this project team very much value addressing health disparities and racial inequities across the behavioral healthcare system. And we really think there is space here and opportunity here to develop an additional work group that we did not have set up before, but which we could take nomination for, to be composed of stakeholders, to really look at the installation plan as it is evolving and assure that we're looking from a racial equity lens, and doing everything that we can to drive equity and reduce disparity through this process. And so that is one recommendation we're making. And then we have a General Assembly mandated advisory work group that actually begins tomorrow, that would be informing and assuring that stakeholders are feeling comfortable with kind of the business model ramifications and systems planning with the MCOs going forward. So some of the adaptations and ways that we have already kind of continued our commitment to this process have been, really demonstrating publicly that behavioral health enhancement is an agency priority at DMAS. We're so appreciative that Dr. Kimsey was able to be here with us today to reiterate that and really bring that leadership voice to make that commitment. We've also been working across our agencies and other HHR agencies on this idea that has been going on since the beginning of developing a university partnership for evidence-based practice center efforts that would really align workforce development across our different agencies, that would add some ability to do outcomes measurement, fidelity measurement, cross-agency credentialing for providers in the evidence-based practices. So we've continued to push those ideas along and to think creatively about how to fund them to create a level of innovation and collaboration that we've never really been able to make happen before. So that has still been ongoing throughout COVID.
Melissa, I just want to pause for a second.
Yes.
There was a question about perhaps someone losing audio. I'm just doing another sound check to make sure.
Oh, yes. Can you all hear my voice? Can you hear me well, Alexis?
I can hear you.
I can hear you. And this is Dr. Booker. I can hear both of you.
Okay.
Okay. Thank you for pausing for that.
You might have lost audio.
I'm going to be as loud as I can without yelling and waking up my toddler who's in the next room. So I was speaking about the evidence-based center efforts, and additionally, we've been thinking creatively about additional funds that might be available to support enhancing services, should we have issues, with reallotment. So we've been, trying to think creatively all along the way. We've continued our commitment to the work by developing medical necessity criteria for the services, and assuring that those are ready to go should we be allowed to proceed. And reviewed by the stakeholders. We've been working on drafts of the state plan amendments and have those ready to go. We've been working across all of our agencies to talk about training brainstorms, and like I said, to talk to the developers who are currently training in this atmosphere to understand what that looks like. We've been holding behavioral health enhancement meetings internally every week and cross-agency every other week. And we've been meeting with associations every other week throughout COVID to, discuss the overall status of services, as we want to understand what's happening from the ground in the system as we move forward trying to enhance it. We have also engaged in work that we could do in preparation to assure that the data and metrics that we know folks are excited to see out of GMAS be there as we move forward. So there've been two processes, and I really want to express our appreciation to Dr. Cleo Booker, who has really taken the lead on these processes internally of developing, number one, internal dashboard templates for our services and using technologies that are very newly available to us at DMAS to pull in data about utilization so that we can have a live dashboard to manipulate to look at utilization data along regionality, demographics, length of stay, and other types of outcomes. And so those will be really helpful to us to make sure that we're able to report out on what's happening to services as we move along and as we tweak the continuum of care by enhancing it. Additionally, Dr. Booker has led our Serious Mental Illness Innovation Accelerator program that we've had with CMS, which is a special opportunity to develop dashboards specific to our members who are living with serious mental illness so that we can look at cross-agency data to see their outcomes, to see how they're utilizing care, what they're participating in and what that's looking like. These are both really important deep dive initiatives with data internally that will help us to be able to report out better on what's going on in the system and to look forward to see what we want to drive as our goals. We will be meeting tomorrow for the first time with our Enhancement Advisory Committee or work group that is mandated through the General Assembly to assure that the work continues to move forward on that report. Next slide. Dr. Plaska, do you want to close us out and then I'll do our final at the end of there?
Sure. So thank you all for participating. It's been definitely quite a journey, kind of starting a few years ago. I think Dr. Ward and I are anticipating or coming up on our 2 years with our respective agencies.
We are.
It's August and September. And so a lot of work has gone into laying out the framework for enhanced behavioral health. And so we appreciate everyone's involvement and momentum. Of course, coronavirus throws us a little bit off course, but we do know that we have a North Star that we are aiming for. We appreciate everybody's innovation and during COVID particularly, to continue to meet everyone's needs and appreciate all the feedback that you've all given to the process. If you do have questions, there's also a number of CPHDS members who are panelists here on the webinar that represent our community behavioral health and our licensing areas and are really the subject matter experts to a lot of these services and implementing them, as well as supporting our providers across the Commonwealth. I'd be happy to answer questions.
Thank you, Dr. Plaska. And I just want to add one additional note. We have one piece of news that we wanted to share today. I'm going to turn the mic over to Dr. Cleopatra Booker, who is our senior advisor in behavioral health here at DMAS and who has been a critical member of the team around keeping enhancement alive and well throughout COVID. She has a piece of news that she'd like to share.
Thanks, Dr. Ward. Hello, everyone. I know that many of you have been in communication with me over the last few months here at DMAS, but some of you have been working with me for a few years now in Virginia. At DMAS, I have been serving as the behavioral health advisor, supporting many of the efforts, including behavioral health enhancement. At this time, I would like to inform you all that August 10th, 2020 will be my last day at the Department of Medical Assistance Services. I have decided to accept an executive position within a company, allowing me to transform and lead the innovation of behavioral health care across the United States in over 30 states, and the ability to reach almost 6 million lives. I'm excited about my next steps, but also will absolutely miss this group of stakeholders, my state partners, and of course, this dedicated and committed team here at DMAS that I have had the honor and the privilege of serving with. Although my time here at DMAS has not been very long, my time with working across the Virginia system of care has been. But during my time at DMAS, it has been so rewarding to watch and contribute to so many historical moments in such a short period of time. Some of those historical moments include behavioral health enhancement, responding to COVID-19, and now planning how telehealth will remain an expanded valuable option for delivering behavioral health services in Virginia. It's been such a pleasure working with each and every one of you, and I look forward to the continued work that will be done in Virginia and across the nation to enhance, transform, and integrate behavioral health care. If you would like to remain in touch, you can connect with me on LinkedIn. But I wanted to thank every one of you again for contributing to such a wonderful experience that I've had at DMAS. And please, please, no matter what, keep up the momentum to enhance behavioral health services. Thank you.
Thank you, Dr. Booker, and thank you for your incredible commitment and service during your tenure at DMAS. We would not be where we are at right now without you, and it's been an honor to work by your side and to learn from each other during this time. So thanks so much.
Thank you, Dr. Ward.
I do see that we have a few questions, and we will be able to answer a few questions right now before we sign off. One of them, as usual, is about how people can get access to these slides. We have recorded these calls, the one from 1 p.m. and the one from 3 p.m., and we've tried to stay on script, so they should be very, very similar, including laughs about the coronavirus grumpy face, and those will be uploaded to the DMAS website as soon as we can, and the slides will likewise be uploaded, and then we will send these slides out to the behavioral health stakeholder distribution list. And we'll do that as soon as we can. I'm seeing there's a question about from Debbie Bonnewell. What services are you anticipating to serve kids as they return to school? Well, that is a very layered question, Debbie, as there are many unknowns at this point about when children will physically return to school and the variability with which they will return. One layer across regionality and locality, and second layer across the health and safety plans that are established and adapted by those localities and approved by the DOE. And then thirdly, of course, how coronavirus continues to evolve and the implications that that bears for all of those plans for participation in school. So, what we can say is there are no services that are stopping in terms of their allowance to be, there are no services going away for children. There's only services being added through enhancement. So the addition will be multisystemic therapy, functional family therapy, and hopefully a rise in children's mobile crisis that would be enabled through the comprehensive crisis implementation. In addition, partial hospitalization, intensive outpatient programs for children. So, we anticipate that enhancement would bring the addition of more services and options for children and families. And, if this is a question in particular about school-based services that are traditionally delivered and reimbursed through the school systems, that will vary, and it's something that we're watching and that we're in conversation around with DOE. We had a call with them last week or was that the week before? They all run together to plan for what we can do to work together and support school localities in understanding navigation of the mental health system within the Medicaid benefit during this very complicated time. So, we are hoping, for example, as these new enhanced services hopefully come online, that we would be able to help locality systems understand how to access them, so that if kids are identified through whichever mechanism they are able to in terms of contact with children, that they'd be able to refer them. So that's my best answer for now, Debbie, but if you would like more information, you can always email our enhanced BH at dmas.virginia.gov address, and I'd be happy to go into more with you if that's not sufficient. Christina Green has a question. Will the SMI waiver look similar to the ID waiver where services are inclusive in the waiver? So I guess the best comparison I would give Christina would be that the SMI waiver is a bit more like the arts waiver that allowed for expanded services, residential services for those who have substance use disorders. So this would be an expansion of higher level services that could be, right now, for example, we don't pay for residential services for adults in the Medicaid benefit. That can only be done through an SMI waiver. So it would allow for kind of that additional level of care that we are not currently able to, we don't have the authority to reimburse for. And the idea there is the CMS and the federal government is reticent to allow us to allow for more reimbursement of higher levels of care when we don't have a really well built out evidence-based, community-based system. So they want to see that we have that in place before we create more beds, essentially, and more places for people to live out of home. They want to see that we really have the referral base and those services in the community to so that we don't develop further reliance on beds and institutions for people to live in.
I just wanted to also clarify that the ID waiver, when we refer to it, is really a home and community-based services waiver, where the SMI waiver that we're referring to as part of behavioral health enhancement is really an IMD waiver, institution of mental disease waiver. So there are different waivers, you know, similar to the ID waiver that you might be more familiar with here in Virginia about home and community-based settings. So this is a little bit different. So we probably should get a little bit better about when we say waiver. There are so many different types of waivers that Medicaid applies for. So just to kind of clarify that as well.
Thank you, Dr. Plaska. Always filling in the other side of my sentences, and I'm so appreciative. I don't see any other questions coming up right now. Yes.
There's a question from Cynthia. Has strengthening families been considered as a science-based intervention with families?
Can you say that again?
Has strengthening families been considered a science-based intervention with families?
I could pull up the literature pretty quickly, but I do believe this is just going to rely on the evidence base stored in my head. But I do believe that strengthening families does have an established evidence base. But for which problem areas across the evidence base, and when we talk about problem areas in the evidence-based literature, it's talking about presenting problem categories and populations. So for example, you know, for trauma versus disruptive behavior, and on the fly, let's see if I can pull it up real quick. I can't say the level of evidence, but I do know that they do qualify as an evidence-based practice according to a number of different clearinghouses. And I remember them as some part of the Family First Prevention Services discussion, but I can't remember where they fell in that new clearinghouse that is being established. I do remember they are a SAMHSA model program. And the World Health Organization has recognized them. So that is what I can tell you. They are an evidence-based practice. And I'm not sure if there are follow-up questions about strengthening families, but if you have them, you can always email our enhanced BH email address, and we would be happy to talk more about that evidence-based practice. Oh, and thank you for the very nice comment from Jennifer Switzer just now. You know, I want to, since there is a specific question about an evidence-based practice, just want to note that there are some practices that were kind of called out specifically. For example, multi-systemic therapy, functional family therapy, where we kind of call them out specifically around a rate and putting them as a specific service into the proposed continuum. And that's really based on like level of evidence and also precedent. Like there are other states that have a specific rate for MST, FFT, and Medicaid. And there are over, if we're talking about children and families, there's actually over 1,000 evidence-based protocols at this time that are published for children and families. And obviously, we're not at a state of innovation where Medicaid programs have individual rates for every single EBP that exists, nor do we have a workforce or a feasibility around training people in that many EBPs. So sometimes it's about level of evidence, level of dissemination and adoption by states. And we haven't gotten down into the nitty gritty of a lot of the other evidence-based practices that we would hope to bring into the system, though we hope that we will follow in the steps of other large systems like Los Angeles County that implemented over 30 evidence-based practices in its prevention and early intervention transformation. But that's down the road for us as of right now. We're really just focused on getting these initial reallotment of this first step where we really want to demonstrate for the state and and that includes you, for the stakeholders, that we can do this together, that we can make this happen. And hopefully more opportunities will flow from there. Any other questions coming into the host or other places that I can't see that we want to try to address today before we go?
I do not see any unanswered questions.
Okay, well, if that's the case, I just want to thank all of you again, in particular, knowing that you are out there in the field during this really challenging and unprecedented time in behavioral health services. We know that you're working incredibly hard and that your staff are making incredible sacrifices and being flexible and committed to the members that we all serve together. And we just couldn't be more grateful for that commitment and that flexibility. And, we are working hard to keep up our end of the deal and do what we can to keep these flexibilities in place, to keep enhancement going forward. We are all committed to the continued improvements of these services for the people that really are close to our hearts and brought us into this work. And we are appreciative for your partnership in that and look forward to continued communication. This was really meant to just be an update to let you know that we are holding that candle, that we are keeping this going, and that we will continue to do so through the course of the implementation. So thank you so much for being with us today and look for updates to come. That's all.